Good evening, one and all. On behalf of Dr. Agarwal's Institute of Optometry, I extend a warm welcome to each and every one of you for the 21st episode of Optometry Series 2.2. And in today's episode, last episode we saw about the retinal diseases. So obviously today's episode is going to be about visual pathway, and we know that. And Anshi ma'am and my team member Miss Meenakshi, both of them are here. Hi, both of you. Thank you so much for joining. Yes. So, Anshi ma'am, so last time we had retinal diseases, ma'am. So the next topic is going to be about visual pathway, and obviously every episode we are starting to wrap up the last episode also. So we're going to see little about the retina also. But the question now is, who is our moderator? Who you roped in inside this episode?
So today we have Mr. Sivarasu as our moderator, one of my first students from SRM, and he's doing an excellent job at Achyuta. So thank you so much, Sivarasu, for joining us. He's
Thank you.
very good teacher, and today we are going to see how he helps us in moderating the entire visual pathway that we're going to discuss today. So hoping to get a lot of inputs from you, Sivarasu. Over to the MC to introduce Sivarasu and the presenter for today.
Over to Miss Harini.
Hello everyone, I'm Harini from C18. It gives me great pleasure to welcome you all today's episode of Optometry Series 2.2. We have an excellent session planned for today and we are pleased to have with us our distinguished moderator, Mr. Sivarasu Manjunathan. Mr. Sivarasu sir is a senior optometrist and clinical in charge at Achyuta Eye Care, Erode. Sir completed his Bachelor of Optometry from SRM Medical College, Chennai in 2016 and further pursued his Masters of Optometry at Achyuta Institute of Optometry, affiliated with Dr. MGR Medical University in 2021. With strong clinical expertise and academic involvement, Sir is currently serving as Senior Consultant Optometrist and faculty at Achyuta Institute of Optometry, Erode. His professional journey reflects dedication to patient care, clinical excellence, and optometry education. We are truly honored and delighted to have you with us today, sir. Thank you for joining, sir.
Thank you. Yes.
Now, moving on to our speakers for today's session. For today's session, we have two speakers who will be presenting in two halves. The first half of the session will be presented by Ms. Sharon, a third year optometry student, undergraduate student. The second half will be continued by Ms. Meera Jasmine, second year optometry undergraduate student. Ms. Sharon, please start your presentation.
Hello, ma'am. I'm audible, ma'am.
Yes, you're audible, Sharon.
Now, let us see for today's topic, tumors of retina and visual pathway diseases. Now, let's have a recap for last year's session. Tumors of retina. Retinal tumors are abnormal proliferative growths rising from cellular elements of the retina, which may be benign or malignant, primary or secondary, and can cause visual impairment or pose a threat of life depending on their nature and extent. The word benign is means non-cancerous and slow-growing. The word malignant means fast-growing cancerous. Now, let's step into the pathophysiology of retinal tumors. The pathophysiology of retinal tumors varies depending on the cell of origin, but generally involves genetic mutation, cellular proliferation, and tumor growth pattern, vascular changes, and secondary effects. Now, let us discuss in detail about genetic mutation. Mutation in tumor suppressor genes, example, RB1 gene in retinoblastoma leads to uncontrolled proliferative of primitive retinal cells. Loss of cell cycle regulation results in rapid meiotic activity and tumor of formulation. And the next is cellular proliferation. Tumors raises from specific retinal components such as neuroblastic origin into retinoblastoma, Galen origin into astrocytoma, vascular and mesodermal origin into hemangioma. Abnormal deficiency of frontal expansion of these procedure of mass lesion. And the next is tumor growth pattern. Endophytic growth into a vitreous cavity and exophytic growth into subretinal space causing retinal detachment. And progressive enlargement may cause this. Vitreous seeding, subretinal fluid accumulation, and optic nerve invasion. And the next one is vascular changes. Vascular tumors, example, hemangiomas, involve abnormal capillary proliferation. Increased vascular permeability leads to exudation, macular edema, secondary retinal detachment. And the last is secondary effects. Raised intraocular pressure leads to secondary glaucoma, retinal detachment, optic nerve compression, and extraocular extension in malignant cases. So these are all the pathophysiology of retinal tumors. And now we are stepping into the classification of retinal tumors. Primary retinal tumors are neuroblastic tumor, retinoblastoma, retinal astrocytoma. Mesodermal and vascular tumors are cavernous hemangioma and phacomatous. Van Hippel-Leyden disease, tuberous sclerosis, neurofibromatous, Stargardt-Weber syndrome. Commonly seen retinal tumors are retinoblastoma, which is the most common intra-malignancy of childhood, rises from primitive retinal neoblasts, usually presents before 5 years of age. The clinical features of retinoblastoma is leukocoria, which is white pupillary reflex, most common, strabismus, decreased vision, and nystagmus, and the types of endophytic and exophytic. Endophytic is which grows into the vitreous, exophytic is which grows into the subretinal causing retinal detachment and diffuse infiltration. Complications are optic nerve invasion and extraocular extraction. And here is a picture of endophytic and exophytic and diffuse infiltration. The treatment of retinoblastoma are conservative management group A to D, systemic chemotherapy of CEV regimen, followed by focal therapy, cryotherapy in the anterior tumors, lasers and chemotherapy, posterior tumors and radiotherapy. EBRT, which is rare last remaining eye. Enucleation of group E advanced disease. Indications are large tumor filling globe, optic nerve involvement, neovascular glaucoma, anterior segment involvement, no visual potential. Long optic nerve stump should be taken during the surgery, and post-operative chemotherapy along with radiotherapy if optic nerve and choroidal invasion is present. Prognosis: untreated is fatal. Early enucleation is 70 to 85% survival. Poor prognostic factors are optic nerve invasion, massive choroidal invasion, and undifferentiated tumor cells.
Yes, Meera, please continue the presentation.
Let's continue the other classification of primary retinal tumors. The first is retinal astrocytoma. Retinal astrocytoma is the benign glial tumor, and it is often associated with tuberous sclerosis. It appears as yellow-white nodular mass and mulvet-like calcified lesion. It is usually asymptomatic and rarely requires treatment unless causing complications. The next classification is cavernous hemangioma of retina. Cavernous hemangioma of retina is a benign vascular tumor. It appears as cluster of thin wall macular aneurysm and grape-like vascular lesion. In this fundus photography, you can see the gray bright vascular lesion. And this is the unilateral condition. It may cause vitreous hemorrhage. The treatment rarely needed unless complication occurs. The next classification is phacomatoses with retinal tumor. Under this, they are the condition von Hippel-Lindau disease, tuberous sclerosis, neurofibromatosis type 1, Turk-Weber syndrome. The condition von Hippel-Lindau disease involves the gene VHL gene mutation, which is the chromosome 3, and it is an autosomal dominant. The retinal lesion of this condition is retinal capillary hemangioma. The ocular feature of this condition is dilated feeder vessels, exudation, retinal detachment. The systemic feature of von Hippel-Lindau disease is CNS hemangioblastoma, renal cell carcinoma, and pheochromocytoma. The next condition is tuberous sclerosis. The gene involved in the tuberous sclerosis is TST1 or TST2 mutation, and it is also an autosomal dominant. The condition of this condition retinal lesion is retinal astrocytic hematoma. The ocular feature of this condition is mulberry-like calcified lesion. The systemic feature of the tuberous sclerosis is seizure, intellectual disability, adenoma pubescens. The next condition is neurofibromatosis type 1. The gene is chromosome 17. And also, the retinal lesion of this condition is retinal astrocytoma, which is a rare condition. Next, the ocular feature of this condition is optic nerve glioma and fish nodule. The systemic features are cafe or leg spot and neurofibromas. The last condition is Turk-Weber syndrome. It is a sporadic and a vascular malformation. The retinal lesion of this condition is diffuse choroidal hemangioma. The ocular feature of this condition are red-orange fundus, which appear like a tomato ketchup, and glaucoma. The systemic feature of this condition is port vein stain, trigeminal area is affected, then the leptomeningeal angioma. These are the signs of the picture. This is the tuberous sclerosis, and this is the sign of von Hippel-Lindau disease, which we have discussed before. Then this is the sign of neurofibromatosis. The signs are light brown spot on the skin, soft bump on the skin, neurofibromas, and the leads nodules, it can be seen in the eye. This is the sign of the Turk-Weber syndrome. And here we can see the port vein stain also. Now the treatment of the retinal tumor, which is enucleation. Enucleation is defined as the surgical removal, excision of the entire eyeball, leaving the extraocular muscles and orbital content intact. It is performed under local anesthesia in adults and general anesthesia in children. The indications are absolute and relative. Under absolute, retinoblastoma and malignant melanoma. Under relative, painful blind eye, severe ocular trauma, antennae staphyloma, and thesis bulbi. The surgical procedure involves 6 steps. The steps are conjunctiva and tenon separation, extraocular muscles, optic nerve section, removal of eyeball, orbital implant insertion, and finally the closure. We have completed the retinal tumors. Now we are moving on to the anatomy of the visual pathway. The anatomy of the visual pathway. Now the definition. The visual pathway is the neural pathway that transmits visual impulses from the retina to the visual cortex for perception of vision. The components of the visual pathway are optic nerve, optic chiasma, optic tract, lateral geniculate body, optic radiation, and visual cortex. This is the anatomy of the visual pathway. Now, the first component is optic nerve. Let's see about it. Optic nerve, the second cranial nerve, it extends from the optic disc to the optic chiasma. It is the backward continuation of the nerve fiber layer of the retina and consists of axons of ganglion cells, which is the second order neuron. It is also carrying afferent fibers of the pupillary light reflex. The morphological characteristics are embryologically and structurally, the optic nerve resembles a CNS tract rather than a peripheral nerve. It is not covered by neurolemma, so it does not regenerate after injury. It contains approximately 1 million fine fibers, which is 2 to 10 micrometer diameter. It is covered by meninges, including the dura mater, arachnoid matter, and pia mater. Subarachnoid and subdural spaces are continuous with those of the brain. The total length of the optic nerve is 47 to 50 mm. There are four parts of the optic nerve. They are intraocular, intraorbital, intracanalicular, and intracranial. The length of the intraocular is 1 mm. The important features include it begins at the optic disc and passes through lamina fibrosa. The length of the intraorbital is 30 mm, which include the feature S-shaped course allowing eye movement. The length of the intracanalicular is 6 to 9 mm. The important feature of this intracanalicular is it passes through optic canal and related to ophthalmic artery. The length of the intracranial is 10 mm. The function of the intracranial, it lies about cavernous sinus and joins fellow nerve to form chiasma. The next component is optic chiasma. Optic chiasma is the flat-ended structure, 12 mm horizontally and 8 mm anterior-posteriorly. It is located over tuberculum cellae and diaphragm cellae. It lies above the pituitary gland. Next, moving on to the fiber arrangement. There are two retinal fibers are involved. One is nasal retinal fiber and the tempororetinal fiber. The nasal retinal fiber, which is responsible for the crossing over, and the tempororetinal fiber remains uncrossed. Thus, the left hemisphere is responsible for the right visual field, and the right hemisphere is responsible for the left visual field. Pituitary tumors cause bitemporal hemianopia due to supracellular extension. Moving on to the next component, that is optic tract. Optic tract runs from the posterior lateral chiasma to lateral geniculate body. Each tract contains two retinal fibers, which is tempororetinal fiber and nasal retinal fiber. The tempororetinal fiber, which is of the same eye, and the nasal retinal fibers, which is of the opposite eye. Each tract carries contralateral visual field information. Some fibers go to the pretectal nucleus, which can be seen in the pupillary reflex, and the other goes terminate in superior colliculus. Next component is lateral geniculate body. It is the oval structure in thalamus. It is the relay center of the visual pathway, and it has 6 layers of gray matter alternating with white matter. Lateral geniculate body in the second order neuron synapse with the third order neurons here. The next component is optic radiation. Optic radiation are also called as geniculocalcrine tract, which is formed by axons of third order neuron. It is extended from lateral geniculate body to visual cortex. It is divided into Mayer's loop and parietal fiber. Under the Mayer's loop, it has inferior retinal fiber and carry the superior visual field. Under parietal fiber, it has superior retinal fiber and carry the inferior visual field. The last component is visual cortex. It is located on medial aspect of the occipital lobe around the calcarine fissure, which is subdivided into 3 areas. Area 17, striate cortex. Area 18, peristriate. Area 19, which is parastriate. The area 17 has the function of primary visual perception, and the area 18 is responsible for the function visual interpretation. The area 19 is responsible for the higher visual integration. Now moving on to the blood supply of visual pathway. It is mainly from pial network of vessels. The blood supply in the central retinal artery plus the pial vessels is responsible for the orbital optic nerve. Then the circle of Willis branches is responsible for the optic chiasma. The posterior cerebral artery is responsible for optic tract, lateral geniculate body, and the visual cortex. Now, getting into the visual pathway lesions. Optic nerve lesions. The optic nerve lesions has two, it consists of two. Distal optic nerve lesion and proximal optic nerve lesion. Under the distal optic nerve lesions, the salient features are marked loss of vision or complete blindness, which is ipsilateral. Absent direct reflex, which is in the affected eye. Nothing but the direct reflex is absent in the affected eye and the consensual reflex is absent in the opposite eye, but the near reflex is present. The common causes are optic atrophy, traumatic evolution, indirect optic neuropathy, ischemic optic neuropathy, acute optic neuritis. The next nerve lesion is proximal optic nerve lesion. The features are ipsilateral blindness, contralateral hemianopia, loss of direct and consensual light reflex. The near reflex is intact. Chiasmal lesions. The causes are intrinsic causes and extrinsic causes. Intrinsic causes involves the glioma, multiple sclerosis. Extrinsic causes is the most common, which includes the pituitary adenoma, craniopharyngioma, and meningioma. The other causes are metabolic, toxic, traumatic, inflammatory. The inflammatory causes include the sarcoidosis and lymphoid hypophysitis. Types of chiasmal syndrome. There are four types of chiasmal syndrome: anterior chiasmal syndrome, posterior chiasmal syndrome, middle chiasmal syndrome, and lateral chiasmal syndrome. Anterior chiasmal syndrome, which is the junction scotoma, central scotoma in one eye, temporal hemianopia in other eye. Next, the middle chiasmal syndrome, bitemporal hemianopia, bitemporal hemianopic paralysis of pupillary reflex, rarely binasal hemianopia. Posterior chiasmal syndrome, paracentral bitemporal defect, visual acuity preserved, color vision preserved, may cause contralateral homonymous hemianopia. The last lesion, lateral chiasmal lesion. The features are binasal hemianopia, binasal hemianopic pupillary paralysis, partial descending optic atrophy. And the causes are third ventricular distension, adenoma of carotid or posterior communicating artery. Retrochiasmal lesions. Retrochiasmal lesions involve the optic tract, lateral geniculate nucleus, which is present in the lateral geniculate body. Then optic radiation, visual cortex, which is nothing but present in the occipital lobe. Then the common feature is contralateral homonymous hemianopia. It may be incomplete, congruous, incongruous, or complete, which is depending on the level of lesion. The first lesion is optic tract lesion. It is consists intrinsic, extrinsic. The intrinsic is demyelinating disease and the infarction can be seen optic tract syndrome type 2. Then extrinsic, pituitary adenoma, which is the most common, craniopharyngioma, optic thalamic tumors, the large aneurysm, superior cerebellar, posterior cerebellar artery. The other, syphilitic meningitis and the tubercular meningitis. The characteristic features includes the visual field defect. Under the visual field defect, incongruous homonymous hemianopia. The right tract lesion leads to the left homonymous hemianopia and the left tract lesion leads to the right homonymous hemianopia. Next, the pupillary reaction. Wernicke hemianopic pupillary reaction, contralateral hemianopic pupillary response. Next, optic disc. It is the descending partial optic atrophy. Temporal pallor, which is the ipsilateral side, and the bow tie atrophy is contralateral side. Lateral geniculate nucleus lesions. The features are incongruous homonymous hemianopia, pupillary reflex is normal, partial optic atrophy is possible. Next, the optic radiation lesions. The causes are vascular occlusion, tumors, trauma, temporal lobectomy. At the site of temporal lobe, the superior quadrantopia defect can be seen, which appears as the pie in the sky. Then at the site of parietal lobe, the inferior quadrantopia, the defect can be seen, which can be appears as the pie on the floor. And at the site of entire radiation, complete homonymous hemianopia with or without macular sparing can be seen. Under this, the pupillary reflex is spared and no optic atrophy. The last lesion is visual cortex lesion, which is present in the occipital lobe. At the PCA occlusion, it caused the congruous homonymous hemianopia with macula sparing. At the occipital tip, it caused the macular defect. At the site of bilateral occipital lesion, it caused the ring scotoma. Then, at the site of bilateral macular cortex lesion, the cause is bilateral central scotoma. The lesion at the optic nerve is the monocular blindness, and this is as the lesion of the proximal part of the optic nerve where the junction scotoma and the temporal field can be seen. The lesion at the optic chiasm, we can see the bitemporal hemianopia defect. Next, the lesion in the lateral chiasma, the binasal hemianopia can be seen. At the lesion of the optic tract and also the lateral geniculate body, we can see the right homonymous hemianopia, and at the lesion of the lateral geniculate body also we can see the right homonymous hemianopia. The lesion at the temporal and parietal lobe of the optic radiation are right homonymous inferior quadranotopia and the right homonymous superior quadranotopia. The lesion at optic radiation is right homonymous hemianopia. The lesion at the visual cortex sparing is the sparing macula. Then the lesion at the visual cortex involving macula when the unilateral is only the macula is involved means when the occipital lobe of one hemisphere is involved, the sectoral defects are seen at the center. When it is in the bilateral means when both the hemispheres are involved, the complete macular defect can be seen. So as consolidated summary of all the lesions are represented in this table. Thank you.
Thank you, Meera and Sharon. It was a very great presentation, and you both delivered the contents also nicely. Now, I request the moderator, Mr. Shiva, to add your valuable clinical inputs, sir.
Yeah, it's a good presentation, and it's covered a 20 mark question of entire tumors. Okay, basically, as an optometrist part, a clinical optom, we may discuss with about all the conditions associated with the syndromes and everything. But basic examination has to be done for a neonates who are entering a hospital to find out like a screening coming for ROP screening and routine eye examination. Whatever the condition they coming to walk into clinic, it has to do a basic evaluation like a torchlight examination. Okay, to see the fixation and as well as the occlusion of either eye. So whether the child is allowing the occlusion or not, because if they not doesn't allow one eye to occlude, then the other eye has a visual defect might be there. So there is a one indication we might get. And also by looking at retinoscope reflex. So perform a retinoscope. I will suggest as a clinical optom, I will suggest definitely every optom who is examining a pediatric has to do a retinoscope routinely. Even they come for a just for a redness, whatever it might be, or swelling, whatever it is. But they should be doing a retinoscope perform because it is a non-invasive procedure. You can do it in the over that whereas whether it is redness or whatever it is there. Okay, we might miss something important fatal conditions also, like retinoblastoma. And also we need to examine like if there is a squint present in one eye, and that might not be the reason only the muscle palsy or whatever the reason, but it might also due to the eyes resting positions due to any other pathology in the retina or something like a tumors. So the eyes gone to the exotropic position. So you need to rule out that by examining another test they have mentioned is the red reflex test. Okay, the glow, what you're getting in the glow, even the retinoscope and the red reflex test. The fundus should show a red reflex in the both eyes. That should be equal. It's not even the lesser brightness between the eyes. If it is, then we need to check with the refractive error. But that might be due to the refractive error change, so that that's why the reflex is very dull in that other eye compared with the fellow eye. So we should perform a complete retinoscope, following which with the red reflex also. So I would suggest perform every child who is walking inside a clinic, whether irrespective of any other complaints like swelling, whatever it is, perform a pupillary examinations as well as this visual test just by occluding both the eyes as well as the red reflex and the retinoscope. And when it comes to, because why I'm saying is, we have a clinic in where Dr. Balasan sir is examining for a routine ROP screening every child is coming. So where we found a few cases where with stage 2 or stage 3 ROP, so we will refer immediately. And where we found some babies had a few cases, I think 2 cases we found the retinoblastoma and been referred to Arvind further Thursday clinic. So they found an earlier detection is very important in case of these kind of tumors in the children. Okay. And the next part, when it's come to visual pathway, I would suggest this as an optometric, but more than that, I'll just let finish that one. And this is the part of a optometry, clinical optometrist role in finding out the cause and not only the cause, but the findings what we are getting is very relevant to the clinic, whether the patient is fixating or not. All these things should be performed as an earlier detection can easily find the cause for them. And when it comes to visual field, it is very important because this might be the reason as a loss of visual field could be the finding another condition in the systemic level. Okay. For example, that's very important in case of glaucoma. We'll do all the routine workup, but when it comes to neuropathology, it will be a it will be comparing with, as they mentioned, homonymous and the heteronymous field loss. For example, if it is a younger, less than no, younger adult who is less than 40 to 50, they will able to say that I cannot able to see this side or this side or the sideways or whatever it is, what we mentioned in the previous slides. But when it is too old, like more than 70 to 80 years old, they cannot express whether they have lost the field in the respect to the left side or the right side. So they just come for the visual examination. When they're testing a video, you also should get all the clear information when the patient is appreciating this blurriness and everything. On examination, observe what the patient is responding with the visual acuity chart. Okay, you should not look at the chart alone and whatever the patient is reading up. You should look at the patient and see how they are turning up, whether they are moving the eyes like this to find out, search the letters and reading up, and whether when they are reading up, like a hemionopic field loss patients, they'll read up vision only to the one-sided letters. Like if it is a left-sided or right-sided, respect to that, they'll be reading only one side of the letter. So because that will suggest something they cannot see it in that area. Okay, that also a findings we can able to start an evaluation for the visual fields. But before that, we should perform another few tests also to find out if there is any neurological visual field loss. That is the primary test is they are not mentioned. That is a confrontation. It is a easier test to perform at every clinic because just giving a target and sitting on opposite eye level to the patient and showing from the peripheral vision how much the field is getting. There are two types in it. One is kinetic and the static. Kinetic is we just check the peripheral field, how much it has been extended from nasal and to the temporal as well as superior and inferior to know how much the field patient can able to appreciate. And when it comes to static, we need to check whether the all the four quadrants of the field of one eye is visible or not by counting of fingers of the patient while fixating at your eyes. Okay, this should be performed in every patient if you're suspecting a field loss like a visual acuity I was told to, right? So all these things. When you're performing that, you should be make sure that the patient is looking at you, your eyes, not the fingers. You just need to explain clearly before performing that. And when you're comparing all the four field and do a comparison for nasal and temporal as well when it comes to neurological field loss, because that's where why? Because it might visible, but the clarity of the vision might changes because few cases like a pituitary adenoma and a craniopharyngioma, where the field loss is getting gradually increases from either of superior or from the inferior. Where, for example, in case of pituitary adenoma, the field loss is getting reduces from superior to the inferior. Whereas this pharyngioma, this will be reversed. So when you're checking the for two field, that should be comparing the two field and see. So that we know how much it's getting increased. It's not only misdiagnosed as only superior quadrant field loss alone. And another test is for neurological evaluation, that is a red desaturation test. Okay, it's like a bright red object that can be either your pen cap or a torchlight which has a red color in it, whatever the drug, because it's a longer wavelength, so that can be easily appreciated as a saturation will be higher, so that you can compare between a normal field as well as the non-seeing area to seeing area, even that is in halfway midway through the field loss is getting started to reduce. So normal field, we cannot say definitely between the two fields also the different. Whereas in this test, the desaturation test, we can able to find it. It is similar to the confrontation what I told before. Same thing, you need to upload one patient one eye and ask him to fixate your and just show the red target towards the one field, and which means the nasal or temporal, and muscle the nasal also, and compare the field, how the brightness or the saturation of the red color, which is so brighter, which side you see more brighter, which side you see very less brighter. So that will give you a clue. The field losses in the it is around, it's getting happening, so it's not fully completed, so that you can immediately refer to the neurologist for ophthalmologist for further evaluation and the management. Okay, the red desaturation test. But the test is performed to compare nasal and temporal only. But in case of, as I told, pituitary adenoma, craniopharyngioma to differentiate, we can compare the same thing with the superior and the inferior field loss by checking the red target with the superior loss and then inferior loss. So when you compare these two, that brightness also will give you the clue which side as the lesion is more, whether superior or the inferior. That will give you a clue which can be the diagnosis of the patient when it's undergo MRI and the further evaluation at a neurologist. Another thing is same visual that can be easily picked up in the terms of the torchlight examination, which is a pupillary response. Okay, when you are checking normal pupillary response like a swinging flashlight test, you can able to find out anything. But when you shine the light, in the non-seeing area, the pupil responds very lesser when compared to it is a seeing area. The pupil response will be better and will be more constricted in the seeing area when you shine a light, but it will be less constricted towards the non-seeing area. So through which you can able to confirm the diagnosis whether it can be the field loss. But ultimately, we have to go advise the patient to go for all the HPF visual field or visual field examination has to be done properly to make sure that report has to be compared. And with the people response, and what else? Next is in case of we have to observe the patient's face first, because he might or she might be able to turn and try to able to see you fully, so that's why they'll try to move their heads. Okay, so always look at the patient's face, and that's it. Thank you. This is what I just want to share you.
Thank you so much, sir. We had a excellent session of theory, and your clinical inputs would have brought a complete package of visual pathway lesion sessions. And from the student's perspective, there are a few questions which was
Yes.
answered already from your narratives. But I'll read it for you.
Yeah.
If you wish to add any other points,
Sure.
please let us know.
Sure.
First question is, what kind of symptoms or complaints are represented by the patients in this kind of cases?
No, they'll just say it as a blur. As I told, no, very younger, they'll be appreciating the vision loss. That will be like, I cannot see this side, or I cannot see to this side. They'll be, representing very clearly. When it's older age group, they cannot, appreciate what the field loss they have. They just say it's a blur vision. But you need to find out based on the tests what I told before.
Thank you so much, sir. The next question is, how can an optum differentiate various types of lesions?
That is based on the testers, what I told, no? Confrontation, that is a primary test that the optometrist should perform because it's not included in the slides also. But because it's a test, since everyone, if there is a neuropathology is there, just advise directly a visual field test. Before that, you can do a just perform confrontation, kinetic and the static. You got a gross testing of your visual field so that you will be easily identify the cause so that which side is the field loss is more than another side, so that easily detectable.
Thank you, sir. The next question is, along with visual field defects, what other findings can indicate lesions in visual pathway?
In case of like I don't second, what are the findings?
Sorry, I'll repeat again, sir. Along with
Yeah.
visual field defects, what other findings can indicate lesions in visual pathway?
Yeah, that is another good question. So the examination, for a complete examination, that includes a fundus examination, where we see that the optic disc changes like a pallor, or there's we call it as a temporal pallor, that will more indicative of the pituitary adenoma or something in the cranial area. So that will be a good finding, so that we can able to advise them for go for a field test.
Also, will there be any changes seen in pupillary areas and color vision with respect
Yeah,
to visual
that's
pathway
yeah,
lesion?
respect to which. Yes. Yes.
Thank you, sir. The next question is, from the optometry perspective, what are the battery of tests that has to be done to assess neurological cases?
Yeah, as I told, first one is a complete history, clear history has to be obtained from the patient, because yeah, they'll be saying a blood only, but you should ask all the like if you're suspecting a neurological evaluation, you should ask in the side தெரியுதா இந்த side தெரியுதுங்களா எப்போல இருந்து தெரியல எந்த பக்கமா, they'll be saying as a they walking towards one direction because they cannot see the other field, so they'll be turning the face and walking towards that one direction. The history has to be obtained clearly, and as like visual acuity examination has to be gone, and you need to check whether the patient is reading up to the entire chart, or is missing up half of the letters. And pupillar examination, torch rate examination, and if you suspect a field loss, then you should go assess the confrontation as well as the color vision. And all these things have to be done. So you need to examine the slit level examination for anterior segment as well as a posterior segment to rule out if there are any fundus changes that will corresponding to the field loss. So, and then once you got the final visual field summary, whatever it is, then that patient has to be immediately referred to the neurologist for further management. That should be taken as an red flag question that should be referred.
Thank you so much, sir. The last question is, will OCT help us in identification of visual pathway lesions?
With OCT, it is to find neurological only nerve fibers loss and the optic disc or optic nerve had changes only. That won't give you the field loss whether the patient has a field loss or not.
Thank you so much, sir. That's all with the question and answer session. If there is any more questions, we'll get back to you, sir, again.
Yeah, thank you.
Over to Gomati.
Thank you so much, Meenakshi. And Sivarasu, sir, it was great having you with us today, sir.
Yeah.
Thank you so
Yes.
much for accepting our invite, sir. We would like to host you on another wonderful platform, sir, in the near future.
Yeah.
Yes.
Sure.
Anshi, ma'am, would you like to add any points, ma'am?
No, I think it was very comprehensive. Thank you, Sharon and Meera, for such a wonderful presentation. Thank you, Sivarasu, for adding all the points that as a
Yes.
clinical optometrist we should remember. So I'm very happy to see how he is, thinking and saying, and I can see see how he's actually imagining if this patient has come, this is what we should have done. So it was very nice the way you presented, and
Yeah.
you helped all the students to understand all the tests that you mentioned are very, very important. Few things like from the beginning, history is very, very important. Look at what the patient is trying to tell you, observe the patient. So those are two very, very important points which Sivarasu has brought about. And very simple tests like just confrontation or an ampular or just doing a pupillary evaluation, these few bits can help us identify a neurological problem immediately, and we can help the patient. So thank you for bringing that out very beautifully, Sivarasu. And
Thank you,
over
sir.
to you, Gomati.
Thank you, Anshi ma'am. That was a wonderful presentation, Meera and Sharon. Best wishes for your future also. Thank you so much, Sivarasu sir, once again.
Thank you.
Yes, Anshi ma'am and Meenakshi, thank you both of you for joining with us today also. Dear audience, thank you all for your continuous support towards Optometry series. If you like this video, give a thumbs up and share with all your friends. The announcement for this particular week is that admissions are open for Pan India internship and fellowship courses in optometry at Dr. Agarwal's Institute of Optometry. Bye, everyone. Meet you in the next episode.
Thank you.
Thank you, ma'am. Thank you, sir.
Okay, thank you.